A new day, and we have subject of discussion shock. A quick review of this one. By definition, shock is a clinical state that occurs from imbalances between oxygen supply and oxygen demand. As a result of these processes develops tissue hypoxia. Tissue hypoxia is like in the center of all these events. I mean pathological factors that develop this tissue hypoxia, and after this hypoxia we will have organ dysfunction that will worsen the condition and the shock by itself. How we classify? We have two classifications, physiological and clinically distinguished. Physiological, we have four types like hypoxic, anemic, stagnant, and histotoxic. Hypoxic mean, for example, a decreased partial arterial pressure of oxygen, and for sure will decrease in venous too. Anemic is from decreased erythrocyte count and hemoglobin concentration. Stagnant is about the heart, it's a decreased cardiac output, and histotoxic can be like cyanide intoxication. If to talk about clinical classification, we have cardiogenic, that is mostly from acute myocardial infarction, myocarditis, or very rare but also valvular abnormalities also may be implicated, like a grave regurgitation, mitral or tricuspid. Obstructive type, we distinguish two main conditions here. One for right heart, that is pulmonary embolism and overwork of the right ventricle, and a global obstruction, that is cardiac tamponade, because heart is like trapped and cannot fill properly and cannot expose the blood to create a normal cardiac output. And hypovolemic is a loss of fluid. Is this hemorrhagic? Is this just sweating, exercise sweat from a hot temperature outside, or this is increased diuresis in many types, like many conditions like diabetes insipidus or diabetes mellitus, fistulas, diarrhea, severe one. Just a septic type is with vessel dilation, total peripheral resistance is decreased, and it's like volume depletion, relative volume depletion. Neurogenic can be like from any blind trauma of the head or a spinal cord injury. Anaphylaxis can be triggered by anything that is strange for our organism, and we can initiate an mastocyte degranulation. It can declare anaphylactic shock, especially in very sensitive patients with atopic dermatitis, asthma, and history of eczema or anything related to allergic reactions. What is the pathophysiology of the shock? Yes, I have marked here three important things. It's cardiac output, it's a heart work. If heart do not pump properly, blood will not be delivered to the tissues. Oxygen supply, it means respiratory system work. It means pressure, arterial pressure of oxygen, that help oxygen to diffuse from blood to be demanded to the blood, and hemoglobin concentration. If we have anemia, it's the same. All of them have like the same priority. If one of them suffer, it's like -1. If to look by cytokines, we have pro-inflammatory and anti-inflammatory cytokines. Interleukin 1, 2, and tumor necrosis factor are the initial factors released in any inflammation. They are called also inflammatory cytokines. This one is a generator of temperature. It's like pyrogenic. Anti-inflammatory cytokines, we know interleukin 4 and 10. All this release of cytokines will promote, if we are talking about vessel membrane, vessel wall, there we have phospholipid or phospholipids and phospholipase A2 that initiates the synthesis of inflammatory cytokines like leukotrienes, like prostaglandins, thromboxane, and also we have promoting of platelet aggregation from thromboxane A2. We have release of nitric oxide at the same side of vessel wall, with vessel dilation, with aggregation, with thrombosis, with formation of reactive species of O2, like with ferrum, with hydrogen. Main points of pathophysiology: cell swelling. But principal suffering part of the cell is mitochondria. Cell swelling and swelling of the mitochondrial membrane lead to impaired flux of water and sodium, and water and sodium comes in mitochondria and lead to swallowing of the mitochondria and the entire cell. Mitochondria lose many calcium, and also is impaired oxidation and phosphorylation reactions in the mitochondria. This loss of calcium will lead to decreased myocardial contraction, and if patient have the compensation from this principal processes, will occur MODS. It's a multiple organ dysfunction syndrome. If we let patient to develop MODS or not let, we have to minimize all inflammation, all symptoms, and reduce the aggravation of state of patient. Patient after developing MODS recover very, very slowly. What is a clinical presentation? A classic clinical presentation of shock. It's a patient is confused, pale, tachycardic, tachypnoic, poorly perfused, oliguric. So shock is decreased of blood pressure and will be poorly perfused, pale mostly for hemorrhagic type, confused because brain have a bad perfusion. Tachycardia, tachypnoia, it's a compensatory, and oliguric. No blood, no renal blood flow, no glomerular filtration rate or decreased glomerular filtration rate. How to assess shock? We don't have too much time for assessing. Initially, we have to give fluids replacement and initiate therapy, as we can know by history what is the cause of this. It is a hemorrhage. We give fluid supply, isotonic, red blood cells. If we have a sepsis, we are giving another thing, but laboratory assessments are also important. So we have to take a blood test to see erythrocyte count. We have to see a clotting, prothrombin, thromboplastin time, bleeding time, electrolytes to see if there is too much or not too much sodium, potassium, urea and creatinine assess renal function, acid-base equilibrium or arterial blood gases. Often patients develop metabolic acidosis. and respiratory compensation in a shock, as usual. Troponins to assess for cardiac myocardial infarction or thromboembolism. Blood cultures if it is a septic shock, to say what is a pathogen agent that declares this shock. EKG, echo if we have to assess properly the heart, chest X-ray or abdominal X-ray if we are looking for some infection, for abdominal for some intestinal occlusion. Spiral CT is most accurate, and a thromboembolism pulmonary, only this one shows us what is the location of embolus. Abdominal ultrasonography if we have a blunt trauma, and after this diagnostic peritoneal lavage, that is an indicator of opening abdominal cavity or not. C-reactive protein, procalcitonin are the good indicators for sepsis, and antithrombin 3, protein C, protein S is they are decreased usually. General measures and won't help us to prevent the shock aggravation, because we cannot treat this in 1 second or in 1 day, and also a recovery is a long period, taking a long period. General measures are oxygen therapy. Yes, you remember a cardiac output, oxygen and hemoglobin. So oxygen supply, if patient have a bad respiratory work, we are intubating this one and attaching to the mechanical respiration on a respiratory machine. Fluid replacement to make a proper cardiac output. Inotropic support if cardiac muscle is damaged, like infarct or not rupture, because on a rupture we have to repair the wall. Diuretics. It is not demonstrated that diuretics really have to help too much, because but we are using to excrete these toxins or anything else through urine. Antibiotics, if we have a source or not, we should give antibiotics empiric, and after we taking a blood cultures, we know which species are, and even to take a sensitivity on which antibiotics to give. Steroids also are given, but they sometimes may worse condition if are given in a high doses, because they are immunosuppressive. So that's all. Thank you for your attention. Hope you enjoyed, and if you like this lectures, you can subscribe. Bye.